Aloha and good morning. It's so nice to see all of you. We're surprised because we've been on the road in Kona and Waimea. I had a feeling, and we all kind of shared, I think Hilo is going to surpass the numbers that have been attending these briefings. So thank you so much. It's great to see you. I'm Lorraine Inoue, the senator. And we're so pleased to have you join us. And just some quick notes because we don't want to miss this great presentation. I'm so pleased that you all thought about at least coming to a presentation that we know our law goes into effect January 2019. And just some introductions. We're so pleased as well, of course, we'll introduce Samantha Trad, and I'll talk about Samantha later, but also to thank my colleagues, Senator Russell Ruderman and Representative Joy, for helping to assist us with the Hilo section. In July, I did attend a national convention for state legislators that I'm always busy with. It seems like I don't have enough work. However, at this large convention of state legislators, normally you have a big convention exhibit hall. And so while I took a break and went to visit who was doing exhibits, I saw this big sign, Compassion and Care. And so I walked around, and Samantha saw my name tag. It says, "We're so pleased. We know who you are. You're one of the biggest advocate for having a choice." Nonetheless, and so we talked, but she did also wanted to share with us what's happening in Hawaii as well, but that she's been working with the Department of Health and will be coming to Hawaii soon, and sort of want to do something to educate our communities. I took up her offer and I said, you know what, why don't you come? And you come to the Big Island, I will help you for Hawaii Island. Our people need to know and understand. And so we're so thankful as well. Let me also introduce Lauren Kim, and he's with the Department of Health. And so Samantha, the advocate for this, she'll introduce herself and say what she's doing. Also, big mahalo, the bosses already also make arrangements to do something. But the one that does the work when you get back to the office, my office manager, Angela Thomas. Yeah. So we set the stage, she did all the work. So we thank her so much for just doing wonderful things with regards to announcements. And so I'd like to also mention that we have Dave here from Big Island Video, and he's going to stay with us the entire session as well, but also to know that when you see the schedules on Big Island Video and Naleo, then you can check the schedules when it's going to be on television on 53 and 54, just 53 on their schedules. And then you can also call your neighbors and your friends and family and encourage them to watch this. And so hopefully they'll run it through the rest of the year. Also, we're so happy that Brenda Ho from Hospice Hilo is here as well. But also we do have, let's see, Laurie Miller from Kauai Hospice is here as well. And so because you guys are the first ones to see the presentations, I was hoping that my colleagues on the neighbor island would do the same for their constituents as well. So she's here checking this up, and hopefully we'll take it back to Senate President's Island on Kauai, and then also offer this presentation to the island of Kauai, and hopefully Oahu and Maui will follow as well, because it's so important. Again, we thank you so much. Many, I see familiar faces here. You remember the struggle we had in early 2000 when we lost by two votes when we tried to get this passed? Well, I was there, and I've been with the program for as long as we can say that we finally got something passed at the legislature. And we thank our colleagues for that as well. Samantha Trad.
Thank you so much. Thank you, Senator. Thank you all so much for coming. Thank you to the Senator for having me here. I'm very excited to be here. My name is Samantha Trad, and I am the Access Campaign Director for Compassion and Choices. And my whole job is to help make sure that qualified patients have access to medical aid in dying in authorized states where medical aid in dying is authorized. And there's many components to that. So I'm going to be sharing a lot of information with you today. And can everyone hear me okay? Okay, I try to project loud. I ask that you save all of your questions until the end of my presentation. My presentation's about 45 minutes long, and at the end, we will have about 30 minutes for questions and answers. And part of the reason I do that is because I think a lot of your questions will be answered during the presentation. There's a lot of information to go over. So thank you again. Thank you so much for having me today. I am with Compassion and Choices. Compassion and Choices is the nation's oldest, largest, and most active nonprofit working to improve care and expand options for the end of life. Medical aid in dying is one of many end-of-life options, and I'm going to focus on that option a lot today because it's new, and I think that's why you're here, but it's one of many end-of-life options. And Compassion and Choices, we're passionate about patient-centered care and making sure that patients are informed and that they're able to receive the care that they want. Life is meaningful because it is a story, and in stories, endings matter. Dr. Atul Gawande wrote a beautiful book called Being Mortal that I highly recommend. And I think stories are incredibly important. They're one of the oldest parts of human life for all time. And so I want to share with you my personal story. For as long as I could remember, my mother had a terminal illness. She was particularly ill in the 90s when Oregon passed their law. So in my family, it was actually pretty common to talk about death. I remember one Christmas, my grandparents bought us all cemetery plots. So my family's a little bit different. And we talked a lot about what a person wants and what end of life means. And my mother was very stubborn, and she always knows exactly what she wants. I'm more wishy-washy. It's hard for me to make decisions, but she always knew, and she would always advocate for herself with her doctors. And so I learned from her how to do that. And we talked a lot about medical aid in dying. We even considered whether or not, if her suffering became unbearable, could we move to Oregon so that she could have that option? But it was impossible. I was in high school. My dad's job was in California. There's no way we could have picked up and moved, and she would have had to find a whole new set of doctors. It was impossible. But from that moment, this issue has always been very meaningful to me. And when I got this job, I was very excited to be able to do something that I care very deeply about. And so I have a lot of intrinsic motivation to be here today to help other people who are facing end of life so that they can have all of the options and decide what option is best for them. I love this picture. It's so beautiful and moving. It's very exciting. It's taken 20 years and a lot of work, and we're very excited that in Hawaii on January 1st, 2019, Hawaii will become authorized to provide medical aid in dying, which is why I'm here today. So, I have some questions for you. By show of hands, how many of you here today are going to die? So it's something we don't like to talk about. It's a little taboo. But I think most of us in this room are probably going to die. By show of hands, how many of you would like to have a peaceful death? Most people, of course, want a peaceful death. Something that you may not have thought a lot about, but what do you consider being a peaceful death? How would you define peaceful death?
Pain-free.
Pain-free?
At home.
At home?
Quick.
Quick?
In your sleep.
In your sleep? Yeah. Maybe with your loved ones. Hopefully at peace. You've made peace with the world. I hope I've made peace with everyone and everything. So most of us would like a peaceful death, and the majority of people say that they would like to die at home. However, that is not always the case. The majority of people end up dying in facilities a lot of time for obvious reasons, but most people would like to die at home with loved ones. Most people say they want their pain and discomfort managed, and it's, of course, very important to have one's spiritual values respected. I'd like to share with you a great resource called Truth in Treatment. You can go to truthintreatment.org. This is a great tool to help people understand about different illnesses and how to have conversations with their physicians. It's very important. I'm going to talk a lot today about having conversations with your physician, with your family members, so that everybody knows what you want. Now, the reason it's important to have things like Truth in Treatment, to have tools like this, is because many people don't always get the treatment that they want. I know from the International Journal of Quality and Health Care has found that 1 in 3 people receive non-beneficial treatments at the end of their life, treatments that they maybe don't necessarily want. The journal also found in 2016 that 1 in 3 cancer patients say that they're not getting enough information about alternative treatment options. So this is a great tool to help you understand a disease that you or a loved one may have, and to help you figure out what kind of questions or conversations you may want to have with your physician. Another great source is the Conversation Project. This has a starter kit to help you talk to family and friends about your end-of-life decisions and their end-of-life decisions too. Many of us have experienced a loved one at the end of their life not necessarily knowing what they want, and it can be very, very challenging. And so it's really important to have these conversations. So what are end-of-life options? There are many. So here's a list of some end-of-life options. Of course, the most popular one, pursuing life-sustaining treatment. Most of us want to do everything we can to continue living. So we try to find life-sustaining treatments to help sustain life. Refusing or discontinuing treatment is always an option. A person hopefully can have that respected. Hospice and comfort care. Hospice is tremendous. Hospice is such a great support for people at the end of their life, and I have heard wonderful things about all of the hospices you have here in Hawaii. It's so important to have that care. Voluntary stopping eating and drinking. It's legal, it happens a lot. People choose to stop eating and drinking, or it's how they end up passing away at the end of their life. Palliative sedation is another option to help a person manage their pain, if they're able to manage it so that they don't feel any pain. And finally, what we're talking about a lot here today, medical aid in dying. Now, it's really important to realize that these options are not mutually exclusive. You can choose more than one option, and a lot of times they go hand in hand. What is hospice? Hospice is a type of comfort or palliative care that provide physical, emotional, and spiritual support to the terminally ill in a home or home-like setting, so that quality of life is maintained and family members may be active participants in their loved one's care. Again, hospice is a wonderful thing when you reach the end of life if you are able to go to hospice and use the care that they have available for you and your family. What is medical aid in dying? It's a safe and trusted medical practice in which a terminally ill, mentally capable adult with a prognosis of 6 months or less to live may request from his or her doctor a prescription for medication which she or he can choose to self-administer to bring about a peaceful death. And I will show you a 13-minute video where you will see a man who has decided to take medical aid in dying. He's qualified for it, and you'll be able to watch the process of how it worked for him. Medical aid in dying is not suicide. In fact, it states very clearly in the Our Care, Our Choice Act that this is very different from suicide. By law, medical aid in dying is not considered suicide, assisted suicide, homicide, or euthanasia. The only people who qualify for medical aid in dying are terminally ill and have a prognosis of 6 months or less to live. These are people who are choosing between a horrendous death generally and being able to control their death by taking medical aid in dying. It's not a choice between life and death. And I think this is really important to talk about because suicide is a very critical issue that does need to be addressed and does need to be talked about. But medical aid in dying is not suicide. And we have a lot of resources here for you today. And if you're interested, we also have a form about why medical aid in dying is not suicide. The American Academy of Family Physicians this month came out with an engaged, neutral policy towards medical aid in dying, which is very exciting. It means that they will support their physicians in supporting patients who qualify for medical aid in dying. And they said that resolved, the American Academy of Family Physicians reject the use of the phrase assisted suicide or physician-assisted suicide in formal statements or documents and direct the AAFP's American Medical Association delegation to promote the same in the AMA House of Delegates. I think about Brittany Menard. Has anybody here heard of Brittany Menard? She was the woman in California who was diagnosed with cancer when she was 29 years old. It was before California had passed their law, and she ended up moving to Oregon so that she could take medical aid in dying. And she was so full of life, and she really rejected the idea that this was some kind of suicide. She wanted to live, but when it was clear that that was not going to happen, and she knew the kind of death that she was going to have because of her terminal illness, she wanted the option of medical aid in dying. The majority of Americans and doctors support medical aid in dying as an option. 73 to 74% of Americans agree with access to medical aid in dying. The majority of doctors support the notion that patients with an incurable and terminal disease should have this option. In Hawaii, we found that there's even more support. 80% of Hawaii residents support the end-of-life care option of medical aid in dying. 76% of doctors in Hawaii support medical aid in dying as well, according to a 2012 survey. Now let me be clear. Just because the majority of doctors here say that they support medical aid in dying as an option, that does not mean that on January 1st, if you are qualified, you can go to your doctor and the doctor will say, sure, yes, let's do it, and walk you through the process. It is a process. This is not a prescription you can pick up in an hour. And there's reasons for that. There's safeguards in place that I'm going to talk to you about today. And it's so wonderful that you're here to hear this information, because a lot of times physicians don't even think about whether or not they would prescribe medical aid in dying until their patients start talking to them about it and ask them about it. Medical aid in dying is authorized in 7 states and the District of Columbia. So in 8 jurisdictions, and Hawaii is the newest one. Yay, Hawaii. The medical community is coming around, and we know that neutral, when somebody has a neutral policy, that means that they support their physicians in supporting patients in providing medical aid in dying for qualified patients. So it's very exciting. The American Academy of Hospice and Palliative Care is neutral. They support their physicians. The AAFP, which I already mentioned, the American Nurses Association, and 10 state medical associations. Medical aid in dying eligibility criteria. So as I said, you have to be an adult, at least 18 years or older. You need to be terminally ill, and you need to have a prognosis of 6 months or less to live, and you need to be mentally capable of making informed medical decisions. So let's go into that a little bit more. A patient must make 2 verbal requests separated by 20 days and 1 written request which can be submitted at any time. So there is a waiting period. The fastest a person could receive a prescription for medical aid in dying is 20 days. And that is if you have all your ducks lined up in a row. So you need to make 2 verbal requests to your physician. 2 physicians must confirm that the patient is an adult, terminally ill, has 6 months or less to live, and is mentally capable. You also need to have 2 witnesses sign the written request attesting to the voluntary nature of the individual's request. You also need 1 psychologist, psychiatrist, or licensed clinical social worker to confirm mental capacity. And finally, the person must be able to self-administer the medication. Other provisions of the law: wills, contracts, insurance, and annuity policies are not affected. In fact, the death certificate lists the underlying terminal illness as the cause of death, because that is the reason the person decided to choose medical aid in dying. Again, medical aid in dying is not considered suicide or assisted suicide. Health insurance. There is a federal prohibition against using any federal funds to go towards medical aid in dying. It was passed in 1997. So Medicare and veteran benefits do not cover medical aid in dying. Now we know from the other authorized states that the majority of people who do use medical aid in dying are on Medicare. And what most people do is they either pay out of pocket or they find supplemental private health insurance. Most private insurance does cover it, and state Medicaid covers it in Oregon and California. And we're really hoping Hawaii's state Medicaid will also cover medical aid in dying.
Samantha, you will see the cost.
Sure. So there's 2 different medications that are usually used for medical aid in dying. One cost around $3,000 and the other cost around $400. So we do encourage physicians to use the $400 medication. It's called DDMP2, and it's a little bit easier to access as well. DDMP2.
And what's the other one?
Seconal. Yes. Those are the 2 most common. So talking about death, I really like this cartoon with the elephant. The elephant says, "Sometimes even if I stand in the middle of the room, no one acknowledges me." Nobody wants to talk about death. We all want to think that we live forever. Maybe I shouldn't say we all do, but many of us don't like to talk about it. It's depressing. But again, it's so important to have these conversations. I encourage people to talk to your physician today and find out if you were terminally ill, if you were qualified, would your physician honor your end of life decision if you wanted medical aid in dying as an option? I've talked to my own family physician about it, and he was really surprised. Nobody had ever asked him about it before, and he'd never really thought about it. And he said, "Well, I think I would. Maybe I would." You know, I know him, and he was like, I was like, "You wouldn't respect my end of life option?" And he finally said, yeah, I probably would, but let's hope we never have to make that decision. Obviously, we don't want to have to make that decision if we can help it. Medical aid in dying in practice. I'm going to show you a 13-minute video now of a man in California who decided that he wanted to have medical aid in dying. He was terminally ill. He knew what kind of death he would get. He knew the different options available to him, and he decided for him that medical aid in dying was right for him. I do have closed captions on if it's difficult to hear. And again, it's only 13 minutes long. And it is very emotional. Let's see if it'll work. Uh-oh.
Nice family.
I think we need to, hold on a sec. I can see it on my computer. Let's see if we can. There we go. It's a beautiful video, and I can put you in touch with the person who made it if you need their contact information. So it's been 20 years since Oregon passed their law, and in that time there's not been a single case of abuse or coercion. There's been no harm to vulnerable populations, including the elderly, people with disabilities, and people of color have not been coerced or abused. We found in all of the states having a prescription for medical aid in dying on hand, just having that option is comforting, knowing that it's a possibility. People use the law to minimize pain and suffering. We've never heard anyone say they do it just to save money. It's to have the end-of-life experience that you want, given the options you have. The type and dosage of medical aid in dying medication prescribed for the terminally ill person can vary with each individual, but it's like how you saw in the video, you drink it. After self-administering the medication, the person usually falls asleep within 5 to 20 minutes and dies painlessly and peacefully within an hour or two. So in Oregon, there's been nearly 2,000 prescriptions written, and only 65% of the people who had the prescription actually took the medication. Most were over the age of 65, and most had a diagnosis of cancer. 90% were enrolled in hospice, and we highly encourage anyone who is planning on using this option to be enrolled in hospice. The primary reason for choosing medical aid in dying was loss of ability to engage in activities that make life enjoyable in Oregon. And again, there's not been one instance of abuse in 20 years. So like I said, we see this statistic again and again in authorized states. About a third of people who go through the whole process and get the prescription never actually use medical aid in dying. They have it on hand so that it gives them peace of mind. So if they decide they want this option, it's available to them. The real impact the Access campaign can make. So as I said at the very beginning, I'm the Access campaign director, and we call it the Access campaign. Compassion and Choices, we work to help states pass these laws, and then we stick around to make sure people have access to it, because just having medical aid in dying be authorized doesn't mean that people are necessarily going to be able to access the law, even if they qualify. Now in Oregon, before we had the Access campaign, there were really only a handful of physicians who were prescribing medical aid in dying. And this was a problem. If you didn't know who to go to get medical aid in dying, then it didn't matter that it was authorized. It was not an option for you, and we don't want that. We want to make sure that everyone who's qualified has the option. So after we started our Access campaign, you can see the number of prescribing physicians shot up by 70%. And this is what we like to see. We don't want there to be just a handful of physicians who prescribe, but we're seeing now where we have the Access campaign in California, for example, the Department of Health put out their 2017 report, and it was clear that most physicians were writing 1 to 2 prescriptions. The number of physicians prescribing was about half of the number of prescriptions written. The Hawaii Access Campaign, passing a law, as I said, that authorizes medical aid in dying is just the first step. Ensuring people understand the process, like we're doing here today, and have a supportive healthcare system is at the core of our goals. The Access Campaign works to educate the public, to empower individuals to know all of their end-of-life options and to decide what is right for them, to educate healthcare systems so that they know how it works. We have a great source called Doc to Doc, and I have flyers over there. If your doctor is hesitant about medical aid in dying, you can share this flyer with them. It's a confidential consultation line that a physician can call, and a physician who's prescribed medical aid in dying before can walk them through the process, can be there as a mentor, can answer their questions for them. We also provide assistance for supportive policy developments. It's really important for healthcare systems and hospices to have very clear policies so that physicians know whether or not the facility will support them in honoring their patient's end-of-life decision of medical aid in dying. We get asked all the time if we have a list of doctors who prescribe, and we do not keep a list of doctors. And there's two main reasons for that. One is safety, but also if we have a list, then what we found is physicians just refer out. They don't want to do it, they'd rather have somebody else do it. We don't want that to happen. We want physicians to feel empowered to be able to do this with their patient if it's what the patient wants. So what we do have is the Find Care tool. And what it is you can put in your zip code, and we put hospitals and hospices that we know that either we know they have engaged neutral policies, which means they will support their physicians if their physicians choose to prescribe medical aid in dying, and we know that somebody has been able to get through the process and receive medical aid in dying at this facility.
Sam, will you say that whole thing again?
Yes.
You just said.
And it's a lot of information. So we put hospitals and hospices here that we have learned to have policies in place in which they support their physicians in medical aid in dying. In other words, you should be able to find a place that will support you if you're qualified in receiving medical aid in dying. Now, if you put in your zip code and your hospital or hospice doesn't pop up, then we encourage you to let us know, and we can work with you to try to talk to them, to try to help them put a supportive policy or a neutral policy in place so that people are able to go there if they're qualified to receive medical aid in dying.
And where is that?
So the Find Care tool is on our website. It is not active for Hawaii yet because Hawaii has not until January 1st. And we are still reaching out to hospices and hospitals. Right now they're putting together their policies. They're deciding what they want to do. I do know yesterday we had the executive director from North Hawaii Hospice, Catherine Werner. The executive director, she said that we can put them on there, that they will have a engaged neutral policy. So we know one that we'll put on there, but it's not yet, not until January 1st.
So that's the website for Compassion and Choices.
Yes, compassionandchoices.org/Hawaii. I'll have it at the end of my presentation, and then we have lots of free sources over here, resources that you are welcome to pick up and take home with you. I will say what we found in authorized states is at first a lot of healthcare systems and hospices are nervous about putting out a policy that supports their physicians in doing this if the physician chooses. So the first year, we may not have a lot on the Find Care tool, but usually it takes a few years for people to see that the sky hasn't fallen, that this is a safe procedure, that it's okay, and we're able to add more and more healthcare facilities. We actually, just last month, we were able to add Banner healthcare systems in Colorado and California to the Find Care tool, which was very exciting. They have 38 facilities in Colorado, so that really helped people, especially in rural areas of Colorado, be able to have access. Huntington Hospital is an example of a hospital that changed its policy. It's in Pasadena, California. I've actually been a patient there before. they did not have a supportive policy. And when the residents found out, they were really upset. And so they tried to talk to the staff there. They got in contact with us. We helped them work with Huntington Hospital to let them know that this is what the community wants. And not only did Huntington Hospital change its policy to support its physicians, they actually took out a full-page ad in the Los Angeles Times explaining why, apologizing, and encouraging other hospitals to do the same. Why the Access campaign is needed. This is Christine Whaley and her husband Tom. When Christine was 36 years old, she was diagnosed with terminal melanoma. And she tried everything there was to beat it, to live as long as she possibly could. And when she was 42 years old, it was clear that there was nothing else she could do. And the end of life option she wanted was medical aid in dying. So when she went and told her physician at Dignity Hospital that that's what she wanted, the physician said, "We don't do that here." It was a Catholic hospital. The vast majority of Catholic hospitals will not prescribe medical aid in dying, and that's fine. That's their religious choice. That's fine. So don't expect any Catholic hospital to have this as an end-of-life option. But for Christine, it was extremely difficult. She was terminally ill, and here she wanted that as an option. She lived in San Luis Obispo, the central coast of California, a very religious area, and she couldn't find a place where she could have medical aid in dying as an option. She ended up driving all the way to UCLA in Los Angeles, which is a 10-hour round-trip drive, to be able to have medical aid in dying as an option for her. She had to get a whole new team of physicians. That drive I've done as a healthy person is not easy. And so for her, they had to go. I talked to her husband about it. They had to have hotels. It was not easy. But at the end of August, she was able to have the death that she wanted with her terminal illness. Her husband said, she played the song, "They're Coming to Take Me Away." She had a great sense of humor. But Christine contacted us because she didn't want anyone else in San Luis Obispo to have to go through what she had to go through to have this option. She wrote a very compelling op-ed in her local newspaper, and we've started a mini campaign in San Luis Obispo to try to get more hospices and hospitals in the area that are not religious to have a supportive policy or a neutral policy that supports their physicians so that that medical aid in dying is an option. And already we found 2 hospices that will now have engaged neutral policies so that others in San Luis Obispo will have that option. I will say also, she didn't know about our Find Care tool. There were places in Santa Barbara that were a little bit closer that she could have gone to, but it's a lot of just working with healthcare systems and helping them to feel comfortable with medical aid in dying. And understand the process, because it's not, it's not the easiest process. So how can you help? We encourage you to ask your doctor about medical aid in dying. If it's an important option for you, let your doctor know that. You are more than welcome to volunteer with Compassion and Choices. Our volunteers are the bread and butter of our organization. I love our volunteers. We are a nonprofit organization, and tomorrow morning I will be giving a volunteer training. So anybody who's interested in becoming a volunteer with us, please let me know, and I can give you the information about our training that we're having tomorrow morning here in Hilo. Connect us with groups or organizations that would like a speaker. Our volunteers will give presentations like this, and if we can, we'll fly out to do presentations. Just last week, Dr. Grube, our medical director from Oregon, met with a number of physicians and gave presentations about medical aid in dying to the medical community, which is extremely important so that they have some reference and can ask questions about the process to a medical doctor who's been through it. And then, of course, if you would like to donate to us, we would greatly appreciate it. Here's our website that I mentioned earlier, compassionandchoices.org, Hawaii. We have a plethora of resources on our website. We have videos, We don't have state forms yet because the Department of Health is still working on that. But once those forms are there, we will have it on our website. You can request a speaker. That's where our Find Care tool is located. I do want to mention too that we really value storytellers. So if you have a story about medical aid in dying, if you are terminally ill and you want to share your story, please let us know if you would like us to help you tell your story, because this issue, I think for a lot of people, it's not really tangible until you're faced with it, and storytellers can really help people to understand why having this option is important. We have a volunteer resource center. We also have materials that have been translated in 6 different languages on our Hawaii website. So if you have a family member who maybe struggles with English or doesn't speak English, you can use those resources and send it to them. And finally, our website is hawaii@compassionandchoices.org. Thank you so much for coming today. I will now do my best to answer any questions that you have. And I know there are other people here who can try to help answer your questions as well. Thank you. Thank you.
Just to let you know that we have some goodies here, and we thank Joy and Senator Russell Ruderman for donating the snacks. So.
Okay. Yes.
Do you know what Kaiser's policy is about this in Hawaii?
I don't know yet, but I know they've been working on it, and I know that in other states, Kaiser's been wonderful. One of the greatest things Kaiser does is they have something called a nurse navigator that helps a patient get through the system, and we highly recommend all healthcare systems have either a nurse navigator or social worker or someone who can help both the physician and the patient go through the process, because it takes 3 different people to confirm diagnosis and the 20-day waiting period, all of it. It's really helpful to have someone. So we don't know yet, but we should find out fairly soon. Yes.
Does Hawaii, I have 2 questions. Does Hawaii's law differ from laws in other places? And number 2, when you talk about neutral position that hospice or other organizations have, what do you mean by neutral position?
Great questions. So first of all, Hawaii's law is very similar. It was modeled after Oregon's law, and it's very similar to the other authorized states. And what I mean by neutral, a very clear, we call it an engaged neutral position, means that a facility will support their physician in honoring their patient if their patient chooses medical aid in dying and is qualified. So that means that the physician is free to prescribe medical aid in dying to their patient if the patient qualifies. Yes?
I have the same question as the previous question. How does hospice work into this in terms of, I know when my husband passed away in hospice, he was able to be given end-of-life palliative care medications. Are they going to be able to participate in this program and give these medications as well?
So it depends on the hospice, and if the hospice has a medical director who wants to prescribe, any physician can opt out if they don't want to prescribe medical aid in dying. I don't know if you guys want to answer it right now, but I know that they're putting together their policies, and there's a number of ways that hospice can be supportive. I know Tom Whaley, Christine Whaley, whose story I shared with you, even though the hospice wasn't supportive at the time for Christine, they did offer free counseling sessions for him. He's able to go to therapy, and their daughters are able to go to therapy provided by hospice. So I think every hospice is different. Do you want to say anything? Does anybody want to say anything?
I'm itching to say
I don't want to put you on the spot, but
information. And thank you, Samantha, coming from California to share this option that we now have. And the debate is not that it's an option; it's a law. So it will be available and accessible, and depending on what you do and how you do that. One of my questions, and just out of to follow up with Amy's question about the neutral engage neutrality. It's kind of a fascinating term, right? So the big thing about this law is that it's optional for all providers. And so the two things I saw on your find was the hospital and hospices. But this is truly and we've talked about this a lot throughout our discussions, this is between your physician and you, not the hospital. By the way, our hospital doesn't have physicians that would be your primary care physician. So I was a little confused about that. And then hospice is not also the primary care physician. We have doctors, but they're related to that palliative care in the hospice model. You still have your primary care physician. So I'm surprised if those are the two options on there, but maybe that's different in California. I don't know. So that would be part of my question, or part of that. And then the neutralities term seems to be a little confusing for me, and maybe it is for.
I have an answer to that. I mean, it could help for that.
Sure, okay.
Go ahead. I worked with Vince Keene and worked
Stand
with.
up so they can hear you.
My name
as
is
well.
Hannah Hedrick. I live in Fern Forest. I've worked with the American Medical Association for 22 years. I know Vince Keenan, who's the executive director of the American Academy of Family Physicians. If you want to understand what engaged neutrality means, I think you gave them information on one of your slides. Go to the AFP website and learn about it. It emphasizes engaged neutrality, and the president, whom I do not know, but the current president of the AFP, gave really an eloquent, he's a hospice physician and palliative care physician. He just gave an eloquent conversation about it. I think that'd be so helpful. I know you're aware of this when we do the Docs to Docs program, but it's valuable for every institution, for every association, for every political body, including our county council, blah, blah, blah. So engaged neutrality, American Academy of Family Physicians. And we're now working for the same thing with the American Medical Association. I'll be meeting with AMA reps. I worked there for 22 years, actually next week.
I'm giving another presentation later today that's specifically for the medical community, and I go into it more for the medical presentation. I don't talk about it as much for the community presentation because I think most people are more interested in the patient side of it than the physician and hospital side. But the reason we have more than just hospitals and hospices that come up. We also have other facilities that come up, and we even include senior living facilities. Even though you may not be able to get a prescription from there, it's important to know, if you can take the medication at the senior living facility. And so hospital systems are interesting because if they don't have a engaged neutral policy, or they have a policy that is not supportive, then even if the physician wants to honor their patient's decisions, they can't. Because the hospital they're not protected by the hospital. And so that's why we encourage hospitals and hospices to have engaged neutral policies so that physicians feel comfortable doing that. And there are medical directors who have written prescriptions, but remember, there's two. You have to have a consulting physician as well. So a lot of times at hospice, the consulting physician might be there. When you're terminally ill, you see more than one doctor. And finding those doctors who will be there for you to help you have that option. So that's why we encourage to have clear policies, and so physicians know too what is my hospice? How do they stand on this issue?
I just finished my question.
Sorry.
Yeah, because I just wanted to make sure.
To add, let me just add something that Samantha did say. For those of you, I know they are health care providers here and physicians. If you want to participate in the 12:30 session, you can come back.
Yeah.
I think it's the same room at 12:30.
It's similar, but I focus more on the provider side of it. So, yeah. Sorry. Go ahead, Brenda.
Finish that little bit of the rest of my statement was it's important that everyone know that Hawaii Care Choices, which is the East Hawaii Hospice and Palliative Care Organization, would always support whatever our patients, they have options, multiple options. So I think that it's the neutrality and the engaged neutrality, what's really important is how individuals see that versus how the policy might unfold within the organization as too far but if individuals want that, there's never a blockage put up to stop hospice care because you've chose to go down this venue. So I just wanted to make sure that that was clear.
Thank you. Yeah, thank you, Brenda.
A non-professional to come to the 12:30?
Sure.
Someone who missed the meeting?
Yeah, we don't check your credentials. It's fine. It might be a little wonkier and not as interesting possibly, but maybe not, right? So absolutely. Yeah, we have the differences just because this focuses more on the patient side and the other one focuses more on provider, but it's the same information. And she asked, sorry, I need to repeat the question so you guys can hear. She asked if somebody who's not in the medical community, if they can come to the 12:30 medical presentation, and of course, anyone's welcome to come. Any other questions? You had your hand raised earlier.
One of the couple of things that stood out for me, the organ, you said in Oregon, most of the patients that participated were cancer patients. Okay. And also came up that there was a complaint that there was a lack of alternative treatments offered or mentioned. So my question is this just a way, it says choices, I don't see many choices. I read this law, I don't see many choices in here. It's pretty much locked up into the medical community, and I understand that. The psychologists and the MDs, I got that. But we've all heard of people that have been told they have 3 months to live, go home, there's nothing else we can do for you, and they've outlived 3 other doctors. So how do we make that distinction between those people that haven't had any other options and we haven't had any other choices? You're not giving them any choices in this law. There's only one choice.
So actually, the law says that the attending physician, the primary physician for the patient, is required by law to make sure the patient knows all options available to them, which I think is really important because it's all about being an informed person. So you know what options are available. Nobody should ever, this is one of many options. And so I think that's really important to understand, depending on what the terminal illness is, where the person's at, the physician will, they're required by law to share all options that are available to that person. And like Brenda talked about, hospice has a lot of different options. I talked a little bit about palliative care, and medical aid in dying is one of many palliative care options that a person can choose from. So today I'm focusing on medical aid in dying because it's new and it is a process to go through, but it's one of a number of options depending on your illness and what you're qualified for. And so the statistic that I talked about at the very beginning, the truth in treatment statistic, it was 1 in 3 cancer patients feel like they're not getting enough information. So whether or not they are getting enough information, I don't know. It was a national study done in 2016. But it's interesting. I know, like I shared at the beginning, growing up with my mother, and this was before, the internet was what it is today, she would really advocate for herself and wanted to know what options were available for her. And, especially back then it was more difficult, but it's why it's so important to talk to your doctor and make sure your doctor and your whole care staff that they know what you want and what you're interested in, and your family as well, because sometimes they may be making that decision. They might be there whether or not they support you in it. Yeah.
Realize this is not telling you this is all you can do with your doctor. It's us that have to make the decisions. You need to ask your doctor what else is available to me. Not accept that, okay, this is such and such and such. Ask why. Why is there nothing else? You need to be your own advocates, not them. It's us that needs to be our advocates. And everybody that has any idea that they are terminally ill, it's up to them to question their doctors as to what is available. You don't just go to a site like this and expect them to give you the options. That's one option they are offering. The doctors need to tell you all your options, and it's up to you to stick to your guns and get your options.
They bring up good points in that the patient has now the responsibility of being their own advocate, beyond being educated, insured, and competent. So now he has to or she has to make the physician come outside of the box, so to speak, because this is not normal practice. So being on the outer islands, I think we do suffer the issue of isolation. We are unaware of the network of physicians out there. I mean, going to an institution is not going to give us the answer. So I feel there are many issues here. And the network is just beginning. And I'm disappointed that Kukuamau is not a part of it because they are good instant online access to all the forms that we will need. So I think there needs to be more work done in the background.
Okay, and I'm not sure why you say they're not part of it.
Like you.
So
Well, I
Thank-
checked,
so-
they're
so-
not involved.
Thank you, and that's why I'm here. We are using our sources to come, and I'll let you talk in a moment, Lori. But I know there's a shortage of physicians as well in Hawaii too. I've read in the newspaper, and that's why being educated is so important. But actually, the president of Kukuamau is here, Lori Miller. And we have been talking to them, and they're very aware of the law. Do you want to say anything?
This is the executive director of Kauai Hospice, but I also serve as the president of Kukuamau, which is the state hospice and palliative care organization. And we have been very involved in understanding how this law has, how this legislation has become law, and working with our members to understand what position we would take as a member organization, because our member organizations are quite diverse and representative of places like Catholic hospitals and health insurance carriers, as well as all of the hospice and inpatient and community-based palliative care outpatient clinics. And so we are very engaged in wanting to understand that we do speak with Compassion and Choices, understand how we are going to see this operationalized, so to speak, across the state. So if you'd like to speak with me further afterwards, I'll make myself available. Again, I'm Lori Miller.
Yeah, and they have a wonderful website that I highly recommend, and they have questions for hospice, and I believe we have Kukuamau's website there on the form so that you can easily access it.
Thanks, Samantha. We have Lauren Kim here with the Department of Health as well. They're the ones that is going to be, is already starting to manage the system. Lauren, some of the questions raised, I think, is important.
And thanks for the opportunity to speak. So my name is Lauren Kim. I'm the policy director for the Department of Health. And my office and myself personally have taken charge of this implementation. The Department of Health is the legal authority, is the legally responsible entity for implementing this law. It is worth noting that I do not have regulatory authority. The law does not give me rulemaking authority, or I do not have enforcement actions that I can take, but it does identify us as the implementing agency. And that's important because the Department of Health cannot force a doctor to participate, or force a patient, or force a pharmacy, or force a pharmacist to participate. And so I can make two broad comments based on some of the information I've heard today and some of the questions I've heard to supplement Samantha's information. It's not normal practice. That is probably the most succinct statement I've heard today. And to change physician behavior, get them to do something new, different, especially if it's maybe scary or they think there's some risk, takes a lot of effort. And we're focusing a tremendous amount of time and energy working with colleagues, professional colleagues and local physicians to get the education out to the doctors. It must be a physician. The psychologists, for example, are having their annual conference in 2 days, and we'll be there on a medical aid in dying track. So we are getting out to the professions. There was a press release. We've seen the Hawaii Herald Tribune and many other papers pick it up, and we have asked health systems to make sure they have policies and procedures in place. But it is not normal practice, and that is where much of the effort is going. And to add to that, the comment about the law requires all other options be made known is the other place we're investing a great deal of time and energy. The prescription gets the headlines and it gets an emotional reaction, but the law says a physician must make available to you all of your options, palliative care, other end-of-life options, et cetera, et cetera, et cetera. And that takes a tremendous amount of work. And we are working with Kukuamau, and I've contracted with them and offered them resources to update their online materials. It's just not quite there yet because we're swimming through a lot. And the other issue is more practical things. And this is where I'm here to hear from the public. I have easy access into healthcare. I work with people in healthcare all the time and have done so for 20 years. I'm a member of the public, but I also work in healthcare. So the very practical questions that I'm hearing about, I live on a neighbor island. Our access issues are much more dire here. That's for sure. That's, we've been working on that forever. I'd like to remind you that telehealth is an available option for this, especially for the mental health consultation. We have very, very strong telehealth laws, thanks to Senator Inouye, Ruderman, Rep. Ventura, passed in 2014, 2016, that requires insurance parity payment for providers for telehealth. It is a real thing, and you need to think about that as an option. It is a permissive law, and I said a pharmacy may choose to participate, but an individual pharmacist may have an individual objection. And we're talking with the pharmacy and with pharmacists and industry to make sure they have procedures in place, that if there's a person who has a philosophical objection when you're sitting at the counter waiting for your dispensing, I'm sorry, 1,000 milligrams of Seconal, this is probably for something I object to. Hopefully that person will go to their manager and another colleague will be able to fill that. But there are a host of practical issues that we're dealing with. Law enforcement response, emergency first responder response. There are a lot of moving parts in the system, so it's quite complex, but our primary focus is on provider education and the patient experience. And I do need to emphasize something Samantha said at the beginning. This is a process. We're going to be carefully watching who patient number one is and trying to assure that that person and that person's family has an appropriate experience, one that is sensitive, one that is compassionate. We don't want to see yellow tape around a house. We don't want to see a police investigation.
It's never happened in 20 years.
It's not happened, but we're making sure by meeting with law enforcement and first responders to make sure that they understand this is what's happening. We don't want bags of evidence being carted away. So it's education at a lot of different levels. But it's a process. It's not going to all be there on day one. We are working on the forms. They're going to change over time. We're going to have word of mouth. And maybe in a few years, it will be less of not normal practice. It'll still probably be rare. Oregon has a population of about 5 million. In a busy year, they maybe have a couple of hundred people who fill the script. Mm-hmm. And as Samantha said, not all decide to take it. So Hawaii has about 1.3 million. Maybe we'll have dozens in a busy year. But again, patient number one, who is that going to be? We need to make sure that person's experience, that person's family's experience is as sensitive and compassionate as possible.
May I respond to
Please.
your question or your offer? My concern is for that family and that individual suffering. I mean, it's like if their world is coming to an end, they are in no shape to be going out there trying to get through the web work that is not in place. So my concern or encouragement might be to get some kind of consultation resource available to them, to their family, so that consistent information is given them and not the quagmire that could happen. It's going to be chaos.
That is our hope, and that is also our concern.
So if there was like one number that family could call, and they could talk them through the process.
And talked about the process, as we discussed in Waimea and Kona as well, that the questions were raised about the law itself. And the questions were raised, why 30 days, why 20 days? And so hearing what Lauren has the hardest job, I think the department is looking at all the obstacles that they're going to be going through and let the law take its place, and whether it's a year or so, that the recommendations probably as the communities hear what's available to them as well, and to see eventually recommendations that come out of communities and requests, that we will probably look at making some adjustments or amendments to the law to see what's best, for the people. Yep. And so that was brought up, and so we're going to give the department, rather than changing it this coming session or whatever, let the law take
place and the process. And then eventually the recommendations from Compassion and Choices as well as the Department of Health. So just to let you know that, we're looking for advice.
State House, Joy San Buenaventura, Vice Chair Judiciary. If you notice, the bill that actually got passed is a House bill. The previous Senate bill died in committee in the House. And because specifically what Senator Inouye, Lauren Kim is bringing up, is that we wanted to make sure that there were safeguards. That's the reason for the 20 days. That's the reason for the self-administration. You have to remember, in the state capitol, we hear a lot about potential abuses, even though Compassion and Choices say that for 20 years, there hasn't been one. We wanted to make sure that Hawaii is not going to be the first case where there is going to be an abuse. We wanted to make sure that we don't hear from heirs saying, the reason why they pushed grandma for this is because they wanted her estate, okay? Or they're tired of taking care of her. We want to make sure that I think we're the only state that required a counselor or a psychiatrist, okay? Because that was during conference, because this went down to the wire, okay? In 2000, when Senator Inouye was in, it died in the Senate by 2 votes. This time around, it died in the House the year before and we killed the Senate bill because we didn't believe it had enough safeguards. So, like Senator Inouye said, I know it is going to be more difficult for the patient itself, but we ask for your patience. We want to make sure it works. We want to make sure that there are no abuses, that the family themselves, especially when there are infighting, and you folks know there's going to be infighting. I am a solo practice attorney. I have done advanced health care directives, wills, and I know between husband and daughter, one wanted to keep her mom alive as much as possible. And I know husband wanted to do whatever it was that was necessary. So even within close family members, there's going to be a problem. So please bear in mind that that's the reason why the legislature passed what we passed, and please work with the Department of Health to make sure that it gets implemented correctly and that there are no abuses. Thank you.
It's really worth it. This gets a little wonky, but not very. The bill we have is something. It wasn't there before, and the form it was passed was enough to get passed. That's what we have to recognize, and I have the constitutional authority to implement the law as it's written. And my friends in the legislature and our colleagues in the legislature, they'll need to hear from us, they'll need to hear from their constituents about what needs to change, what needs to be improved. I agree with Senator Inouye's comments. I don't think it would be wise. I think the risk would be great if we open this up in 2 months. I think we need to kind of see how this goes. But your point of, yes, but still real families will be suffering and making heart-wrenching decisions. We cannot lose sight of that. And so that's why I'm out here in the community. I have staff working on this, working with people like Kokua Mau, talking with the hospices, because at some point it comes down to a decision between a provider and a patient. That's where it belongs. You don't want government regulating this. You want to make sure government is checking out if something wrong is going on, but you don't want government interfering in such a deeply personal conversation, a patient-provider conversation.
Yeah. Thank you, Lauren, and thank you, Representative. So Hawaii's law is based off of Oregon's law, but there are 2 differences. One is Hawaii does have the longest waiting period between the 2 verbal requests, and it's the only state that requires the mental capacity assessment by a psychologist, psychiatrist, or licensed social worker. It's optional in the other authorized states.
People that have Alzheimer's, if they've gotten a diagnosis early enough that they have clear thought, are they able to follow through with this, knowing what's going to happen towards the end?
So it's very difficult because a person has to be mentally capable to make that decision. They have to be able to self-administer. So it's very difficult for someone with Alzheimer's. There are other options for people with Alzheimer's and dementia, and Compassion and Choices. We get asked about dementia and Alzheimer's all the time. And we actually have a big dementia initiative that we're going to be launching in February. It's not going to have anything to do with medical aid and dying, but it's going to be about supporting patients and families who have Alzheimer and dementia. So if you're interested in learning more about that program once it launches, you're welcome to sign up. We have, I think most of you hopefully signed up on the Senator's sign-in sheet, but we have another sign-in sheet if you would like to get our emails. Please sign up there. You can also, if you're interested in volunteering for us, please sign up there. I am here today because access is so important. And just like you said, this is not, on day one, it's not going to be, you're not going to be able to go and get the prescription and have it all done. It's going to take a few years, but it's here and it's starting. And I can tell you our experience from the other authorized states is that it does get easier and easier to access the law. But it really takes all of us who are invested in this. And Compassionate Choices, we are here to support you as much as we can. And so if there's anything that we can do to help support you, please let us know. And we are happy to help. We want to help the patients and the families.
Samantha, can you also add to it, and Lauren, about how one can get the prescription even by mail?
Sure. So we also have, and I meant to mention this earlier, I talked about our doc-to-doc consultation line. We also have a pharmacist-to-pharmacist consultation line, and I have forms on the table for pharmacists to be able to call and talk to a pharmacist who's prescribed before. And the law authorizes medication, the medication should be able to be mailed to the patient who's qualified, which will help on the Big Island. Lauren's looking into it more to make sure there's no other laws or problems that might come up, but in other authorized states it is a possibility, and the way our Care, Our Choice Act is written, it's a possibility. And a patient can also have a designated person pick up the prescription for them as well, because again, we're talking about terminally ill people. It's so difficult to go to a regular doctor's appointment, let alone go through the process. So that's why this is so important to have this education, and I'm grateful to have all of you here today. I'm afraid we're out of time. I don't know if we, a few more last questions, okay?
My name is Lani, and I'm from Hospice of Hilo, now called Hawaii Care Choices. This is going to clearly take some time to get everyone through this whole process, but in the meantime, I want everyone to know that we are the end-of-life experts. And while you are planning, and maybe if you have or have not done your advanced care directive, we currently already work with Lauren, we're already with Kokuamau, we are working with our legislators who want to really support Senator Inouye and then now Samantha. So know that if any of you would like any information on your way out, please stop and see me, because when it comes to end-of-life planning, we are the experts. We are the ones that have the human side of that planning. Thank you so much.
Yeah, thank you. All right, thank you everyone for coming. Thank you.